Today I'm dealing with the topic of soft contact lens fitting and assessment, soft toric contact lens fitting and assessment, and RGB contact lens fitting and assessment. So before I go into the topic, I would like to thank KSOS and the chairperson Vijayalakshmi ma'am and the moderator Seena ma'am and also Dr. Soumya Nambiar for giving me an opportunity to have this talk. So basically, I'll go with what is a contact lens. Contact lens is an artificial device whose front surface will be substituting the anterior surface of cornea. So it's mainly used for the correction of refractive error, irregularities on the front surface of the cornea. So basically, it is considered as a medical device. Classification of contact lenses. There are many classifications based on the anatomical positions, wearing modality, water content, and the material basis and the replacement schedule. So mainly I'm talking about on the material. Material basically soft contact lens, RGB contact lens. So soft, hydrogel and silicon hydrogel, RGB lenses, and there is also a hybrid lens where RGB is in the center and it is surrounded by a soft silk skirt. And also based on the replacement, we have the daily disposable, bi-weekly, monthly, quarterly and conventional lenses. So indications mainly to whom we can give contact lenses is optical mainly for the refractive error corrections of myopia, hypermetropia, astigmatism, uniocular aphakia and also irregular astigmatism and keratoconus. Mainly for therapeutic, for treating any corneal ulcers or for any trichiasis, entropion, ectropion, etc. And for occupational, mainly for the sports people or also for the pilot and also for the actors. And for the diagnostic, mainly we will be giving for gonioscopy and also for the cosmetic purpose if the patient wants color contact lenses, and also for any phthisis bulbi etc. will be treated with cosmetic lenses. So basically there are two fitting criteria for contact lens fitting, mainly the empirical fitting and the diagnostic trial lens fitting. So empirical fitting requires only the patient prescription, corneal diameter and also the corneal curvature. So it's very quicker and time efficient that we don't require a trial lens fitting. We have the prescription, we can fit for the patient. If it comes to a diagnostic or trial lens fitting, it's mainly based on the preliminary examination that the patient have to undergo, and also there should be a good lens cornea relationship with the design what we choose, and finally we have to confirm the final RX which is required. So it will be very helpful in choosing the initial trial lenses. So these are the contact lens workup protocol criteria where we have to undergo before examining the patients. So there should be a preliminary examinations and parameter selection, patient selection, trial lens selection, fitting assessment, over refraction and contact lens dispensing. So there should be a preliminary examination, that is thorough history taking of the patient is very important, where we have to know the previous ocular history and the patients who is previously wearing the contact lenses, and whether what is about their occupation and also the working environmental conditions. So after that we will be coming with the visual acuity, refraction, tear film. Tear film is one of the basic important preliminary examination if it is concerned with the contact lens, because if the patient has a dryness, what type of material we have to give will be depending upon the these tests. And also the slit lamp evaluation, that is detailed slit lamp examination whether patient is having any lid abnormalities or any corneal abnormalities or conjunctival abnormalities will be understood from the slit lamp examination and also the fundus examination. So these are the parameter selections where we have the keratometry or the topography report, where topography report will be very important in identifying the location of the cone for especially for fitting for RGB lenses, and keratometry is mainly for selecting the base curve, and HVID is for selecting the corneal diameter, and it is simply measured with a millimeter scale from the limbus to limbus, and also the lid characteristics whether and also lid donors, whether it is very loose or tight or can be understood, and with a palpebral aperture height can be measured with a millimeter scale. So it varies from the ethnicity, from the Caucasian to the Asians, it will be varying. So it's very important to measure the lid characteristics, and also the pupil size, which is very important as far as concerned with contact lens for the optic zone diameter. So in mesopic condition and also in the bright light conditions, we have to measure the pupil size, and also the spectacle refraction, which is very important. If you have to convert the vertex conversion, and also the spherical equivalent can be done with the spectacle refraction, so we'll get an initial calculation for it. So this is the basic conversions where you will get with base curve calculations, where we have to diopter conversions. It is done with f is equal to n minus 1 by r, where we will be getting the dioptric value. So the reverse we can do for the dioptric to get an conversion also. So if example, you can see there is a K1 of 7.8 and also K2 7.70 So first we have to find the flat K. With that flat K we have to add 0.8 So it ranges from 0.6 to 1 So if we add flat K plus 0.8 we will be getting the base curve as 8.6 So also the base curve ranges from 8.4 to 8.9 and diameter 13.8 to 14.5. This is a range which is selling. It depends upon the company. It will varies. And also contact lens selection, base curve, total diameter, and also the back vertex power. So if we are calculating the total diameter, we have to take HVID plus 2 and base curve we have to add 0.8 to 1 to flat K. And back vertex power have to be calculated with the vertex conversion for spectacle refraction plus or minus 4 diopter. And the material can be choose with hydrogels and silicone hydrogels. So there is a case of K1 44 180 7.67 and also K2 is given. So HVID is 12 so spectacle RX is minus 5. So it is calculated with FCL is equal to FSP by 1 minus D into FSP. So it will be giving a base curve around 8.47 and you have to add HVID plus 2 it will be giving 14 So with that FCL we will get the back vertex power as minus 4.75. So after this selecting, we have to check for the fit assessment. We have to give a proper adaptation time for the patient, and also we have to check for the coloration, centration, movement, whether vertical lens sag, horizontal lens lag, tightness of the lens, comfort, and also the stability of the vision. So the coverage usually say full corneal coverage 1 to 2 If it is greater than 2 overlaps, lens will be large. If there is a corneal exposure, lens will be too small. And we have to check for the vision. Vision clears after blink, it is a steep fit. Vision blurs on blink, it is a flat fit. And also push-up test, you have to check for ideal fit will be saying 40 to 60%. So there will be an easy displacement, smooth recovery and recentration. And if it is 65 to 100%, will be saying a steep fit. And if it is 35 to 10%, it is a flat fit. And we have to check for the lateral gaze position. Optimal movement will be saying around 0.5 to 1 If it is a lateral gaze lag, up to 1.5 is accepted. And if it is by looking up to up gaze, if lens slides up to 1.5 it is a well fitted lens. If the lens does not slide, it means a tight fit, or if slides more than 1.5 it is flat or loose fit. So if it is before going to that, we have to know the thumb rule of if there is a 0.3 change in base curve, there is a 0.50 change in total diameter. So if it is a steep fit, we have to increase the base curve or decrease the dia, or if it is a flat fit, we have to go with decrease the base curve or increase the dia. So in order to make an optimal fit. Next we move on to the soft toric contact lens fitting assessment. So soft toric contact lens is gone when the best sphere does not give a satisfactory visual acuity, and when there is a residual astigmatism that is more than 0.75 diopters, and if there is a residual cylinder which causes very discomfort for the patient, and also when the patient is not comfortable with the RGP, and also when the sphere to cylindrical ratio is less than 4:1. So there are some fitting guidelines for every lenses. For soft toric lens, we have to start with the refraction. So you have to select an initial trial lens, and according to that you have to convert the vertex conversion using a vertex conversion table chart. Then you have to perform a keratometry. You have to choose a trial lens closest to the spectacle axis. Then you have to do a vertex distance compensation for the sphere and cylinder. Then we will do a slit lamp evaluation to check for the corneal coverage, centration, movement, etc. Then you have to evaluate the visual acuity. If there is a lens rotation, visual acuity will not be improved by adding any lenses. So you have to check for the axis compensation for it. So axis fit assessment is seen by different companies are shown over here. Here portion long is shown over here, and also different companies having different orientation mark. That is in order to identify how much rotation has happened and how much should be compensated. So same way we will be covering for the centration, coverage, push-up test, movement with blink, lag, etc. So if there is a 10-degree rotation, usually we say LARS rule will be left. There is a from the practitioner side there is a 10-degree rotation, you have to add, and if it is the right you have to subtract. And CAS rule where clockwise you have to add and anti-clockwise you have to subtract. So there is a case where the spectacle prescription is given. Spectacle prescription is given -1 with -0.75 across 180. If there is a 20-degree nasally side, it is rotating, you have to add 20 to that. So the final prescription will be -1 with -0.75 across 20. So there should be any troubleshoot is the lens rotationally stable. So the troubleshoot can be done with clockwise, anti-clockwise, and other stabilization techniques, which I am not going into it. Prism, Velas, Peri, Velas, so many stabilization techniques.